So, like I said earlier, um, this is me and my family. Alyssa's the one right here in the middle that will always had to wear a skirt everywhere she was, no matter where we were. But she has epilepsy, and it's a very specific form of epilepsy called Dravet Syndrome. It's a very rare genetic disorder. Um, Maybe 1 in 15,000 people get it. Very difficult to treat, and it's been a very rocky road for us. And then I wish I'd had a lot of this information 10 years ago or 8 years ago. It would have been really helpful. But I'm going to try to share as much as I can with you, and hopefully it'll be beneficial to you. So, like Stephanie said, and I said, my daughter has Dravet syndrome. I work for the City of Mesquite Fire Department. Currently, I'm assigned to the Arson division. I'm an arson investigator. I spent a year or the past year training, going through police academy, arson school, and doing the career development program with the police department. I'm also on the Swiftwater High and Go Rescue team, and I'm one of the instructors for that. Before that, I worked in the security industry. I worked for a company called Cochise Consultancy, doing private security in northern Iraq, and I also worked for Ross Perot and Ross Perot Jr. for 4 years doing security for them. And before that, I was in the Army. So what I want to go over with y'all today is going to be just kind of a brief overview of the origins of epilepsy, the impacts it has on our community, the different types of epilepsy and different types of seizures, identify what would be the correct interventions to do, whether it's either you as a family member or if you witness someone having a seizure in the street or in public. And then also the big one is how to assist first responders, how to communicate with them what you saw, what you observed, and then, and to be kind of ready for the questions they're going to ask you. And then I'm going to go over into what it's like to live with epilepsy, whether it's you yourself if you suffer from epilepsy, or what your family member who suffers from epilepsy is going through, or their family members as well. It's a kind of a cascading effect. And then, how you can be a resource to those friends and family as well. So some quick facts about epilepsy is that it was actually first recognized in 1050 BC in Babylon. It was diagnosed as a brain disorder in Hippocratic writings all the way back in 400 BC. Currently, the number of people in the United States that suffer from epilepsy is estimated to be about 3.5 million. About 470 to 480,000 are children. Around 65 million people worldwide are diagnosed with it, and then there's around 150,000 new cases each year in the U.S. that are diagnosed. So the annual cost of epilepsy in the United States is around 12.5 billion with a B. So it's pretty substantial on the totality of the effect, whether it's on the families and the healthcare system and the community. And then epilepsy isn't just it's not just a seizure disorder, it's a spectrum. It covers a full range of cognitive and psychological impacts, along with other physical comorbidities that go along with it. So it's not just a seizure disorder, it's a spectrum of effects that it has. And I try to, it's hard to do on here, but for every class I would do like a little, trivia to see if they could identify anybody that suffered from epilepsy that was famous, or celebrities or athletes or whatever. And a couple just easy ones that I'd pick out is one was Julius Caesar, of course. Theodore Roosevelt, President Roosevelt, had epilepsy. Lil Wayne, John Snelling and Tiki Barber, both NFL running backs. Rick Harrison from Pawn Stars. His epilepsy was so bad as a child that he wasn't allowed to even go out inside and play. He had to stay inside all the time because his parents were afraid that he'd have a seizure, fall down, and hurt himself. And then Hugo Weaving, who was Agent Smith in The Matrix, his epilepsy is actually so bad he has to have a driver take him everywhere he goes. He can't get a driver's license. So what is the definition of epilepsy? So the definition, the current definition, is the occurrence of two or more unprovoked seizures separated by at least 24 hours. And there's currently 25 known different syndromes of epilepsy. But that leads to the question, what is a provoked or unprovoked seizure? So a provoked seizure is febrile. So that's the one where you run into fever, high temperature. Sometimes it doesn't even have to be that high to break that through that threshold and cause a seizure to come through. Or if it's a rapid temperature spike, if all of a sudden their temperature shoots up rapidly, that stimulus, that sudden stimulus change will cause a seizure. And then there's also neonatal. And neonatal can be, that's a seizure that takes place within the first 28 days of life after birth. It can be due to traumatic injury, or it can be non-traumatic in nature. Normally they're temporary. Usually fewer than half of affected infants develop seizures later in life. But however, it can be a symptom of a serious underlying medical condition, and it needs to be researched, it needs to be evaluated, it needs to be checked. And then you have what's called acute symptomatic, and acute symptomatic means sudden onset, rapid onset. And those are usually metabolic, toxic, or traumatic. And by toxic, I mean, drug or alcohol. Traumatic, obviously, is, an injury to the head. So what are some other triggers for seizures? So you have alcohol or drug consumption and withdrawal can cause a seizure. Dehydration, missing meals, stress, hormonal changes associated with puberty or hitting the menstrual cycle, and sleep deprivation, fatigue, and illness can all trigger a seizure. So if you have a seizure that's triggered by one of these events, does that mean you have epilepsy? And the answer is no. It means, of course, I said that wrong based on the slide, but you can have seizures and not have a diagnosis of epilepsy. But if you have a seizure, you do need to be checked by a medical professional to find out, if it was just the fatigue or illness or alcohol or whatever contributed to that seizure. So also, I forgot to hit, like, first seizures, such as febrile seizures, non-epileptic events, eclampsias, are all examples of conditions involving seizures that are not associated with epilepsy. So, and like I said, regardless of what type it is, you still need to go see a doctor when it occurs. So, what are some causes of seizures or epilepsy in children? So, one which I'm very familiar with is genetic. So that, like I said, my daughter has Dravet Syndrome. It's caused by a genetic mutation of her SCN1A splice point in her DNA. I can't explain what that means specifically, but it's a genetic mutation that she inherited from me, and it causes her to have severe uncontrollable epilepsy, but has no impact on me. And they're still not 100% sure why. But genetic is a big influence, and you can also have not just like genetic. You can also have not just gene mutation, but it can be hereditary as well. Head trauma is a big one. So brain conditions such as stroke, or brain tumors can be a cause of epilepsy. Strokes are the leading cause of epilepsy in adults older than age 35. You have infectious diseases such as meningitis, AIDS, viral encephalitis can all cause seizures or epilepsy. And prenatal injury, that's before birth. If there's an injury to the baby while still in the womb, it can cause brain damage that can cause the seizures. There can be other things that are prenatal as well, such as infections in the mother, poor nutrition, poor prenatal care, or oxygen deficiencies during birth. This can cause brain damage, or which can result in epilepsy or cerebral palsy. And then developmental disorders, a lot of times coincide with epilepsy, such as autism, attention deficit disorders, hyperactivity can all kind of go hand in hand with epilepsy. So I'm going to kind of hit the different types of seizures. Everybody has always heard of the grand mal seizure. We try to keep trying to get further and further away from that definition or that name. Technically, it's called a tonic-clonic seizure, and that's your typical kind of, everybody knows what that looks like, but it's the one where you have the sudden loss of consciousness, the generalized stiffening of the body, which is the tonic phase, followed by the contractions of the muscles and the convulsions, which is called the clonic phase. Then you have absence seizures. Some people pronounce them absence, I say absence, but they were previously called the petit mal, but they're the little brief lapses in awareness. Some clonic activity may occur. There may be some tremors, but they're very, very easy to miss. Kind of just looks like they're staring off for a space in a second, and they pop right back in. Then you have myoclonic seizures. Those are the little brief, tenth of a second, sudden brief muscular contractions. They may involve a cluster of them or a group of them that come together, and they can also resemble tremors. Another one that's also very easily misdiagnosed is a facial tic. And then you can have tonic or clonic seizures. You can have one or the other. You can have just a sudden onset of muscle tone or muscle rigidity, or you can have just the clonic phase where you're doing the contractions. And then there's the atonic seizures. Atonic is the sudden loss of muscle tone. If an individual is standing up, he'll all of a sudden just drop to the ground or collapse. Like, it's almost like an electrical switch got shut off and they just fall straight to the ground or collapse on themselves. And then it's over very quickly and they pop right back up. Those are actually very dangerous seizures to have. They result in a lot of broken bones and head injuries. And then there's focal. And then focal can be broken up into with impairment or without. They call it partial or complex. So partial will be without the impairment, without the cognitive impairment, like they're still aware of everything going on along. And then there'd be the complex, where they're having this focal seizure, but they're completely out of it. And the focal seizure will originate within a certain network of neurons that's limited to one hemisphere of the brain. And then the symptoms will depend on precisely where that disruption occurs. So it can be just one hand, or it can be one side of the body, or it can be just in the face. And I've seen it before where somebody has one of these focal seizures, which is affecting just one side of the body, but they're still aware of everything going on and talking to you. So I'm going to show you some videos that will kind of demonstrate each different type of seizure. I'll start with the tonic-clonic and kind of go through it. Some of the videos are a little lengthy, but I'll kind of skip through the long parts to give you the best idea of what these seizures look like. So this is an example of a tonic-clonic. I'll get into more of the correct responses of what you should do when somebody's having a seizure. But I will point out that mom has already placed her on her side, has got something underneath her head to help cushion her head. And then she's allowing her to work through the seizure, not attempting to restrain her, and just providing that positive stimulus and positive support as she's going through it. You have the very you can see the repetitive jaw and mouth movement. She has the fixed gaze. Sometimes you'll have eye deviation to right or left or up or down, depending on where the disruption originates from. But a lot of medics will arrive on scene at this point and think that your seizure is over with and done. And this is something I ran into a lot with my daughter, where she would work through that full tonic-clonic seizure, and then she would still be on the ground laying there doing these repetitive jaw and mouth movements or eye movements. And I had to explain to him, basically, she's still seizing. The neurons are still misfiring. She still needs those rescue medications. So, at this point, a lot of doctors or EMS workers or even parents are hesitant to give a rescue med because they think the seizure is over with. But they can actually be stuck in this repetitive cycle of jaw, mouth, and eye movements for, I've seen it for 5, 10, 15 minutes to where they're continuing the seizure but not getting any rescue meds. So you see that repetitive jaw movement still. So most people would think that the seizure is over with, but it is still going on. But good, positive reinforcement from mom and, big brother, the little poke to the face. So, yeah. So this next one is an example of an absent seizure. Like I said, they used to be called the petit mal. They sometimes have some clonic activity, the little muscle tremors, but a lot of times they can have laughing as well. It's my daughter would do it as well. She would sit there and be staring off into space and laughing, and we're trying to figure out, what is she laughing at in here? But then we realized after the fact that she actually was having these absent seizures. So you can see he's completely out. And, and the seizure's over. Good. Big Sis did a good job catching him. But now he's completely post-ical, completely confused. He stays confused like this for the whole length of the video almost, for a good 5 minutes. So the misconception is that seizure wasn't as strong because it was just an absent seizure. But, as long as he was post-ical and confused after that, that seizure had a big impact on him, and kind of leads into the importance of getting these diagnosed and getting them under control. So this next is an example of a myoclonic seizure. The myoclonics are the ones I said were those little tenth of a second, sudden onset, tenth of a second jerks. It almost looks like they get startled or almost look like they get electrocuted. And it's particularly hard to identify in children because they do so many random odd things. But we had a hard time identifying in our daughter as well. It just looked like she would get startled or have like a little tick. And, she was one of the, we first figured out that she was having these when she had a little stomach bug. And I took her to the pediatrician's office, physically to the actual doctor. And she was having these little ticks, these little, muscle spasms. And he watched her do it, 2 feet from me. I asked her, I was like, okay, now I'm not going crazy, right? You saw that. And he's like, yeah, I think it's probably just, maybe some, flinching from gastric pain or something. But that never even occurred to him that she was having a seizure. So this one here is a lot more pronounced than what she had. But I'll show you another video where they're a little bit more subtle, and it's what her doctor was seeing, and then didn't even occur to him that they were seizures. So, very, very pronounced with her. So, but the next one is a little bit more subtle. And like I said, these are the ones pretty similar to what my daughter was having. Very easily misdiagnosed as just facial tics. But you'll have to watch. But you can see it hit in his arm. and in his face as well. You can see him very subtle, almost look like hiccups. So when he clusters like this for the full 2 minutes of this video. And one thing that we noticed with my daughter is that these myoclonic clusters would sometimes lead up to a full tonic-clonic seizure. So they were kind of, they would be building up to that. And something else that's also kind of prevalent with these seizures is that they can be brought on by sensory input. A lot of times when, like you saw, he was eating, any kind of sensory overload or sensory stimulus, such as eating, trying to concentrate on something like playing a game on an iPad, watching videos on an iPad, or playing in water. Actually, it's such a large amount of sensory stimulus that it can cause those seizures to break through, and you would see clusters of them, or we would see clusters of them, followed by, that was our warning for us that she was going to have a tonic-clonic, was we would see these clusters of these myoclonics, and then boom, she would have a full tonic-clonic. Not always, but it was a good warning sign for us that something was going to happen. So, and this is an example of a focal seizure. This is what I talked about earlier, where they can be partial or complex, and they just affect certain parts of the body. And this one for her is going to be simple. She knows that's going to be happening. She knows it's going to start, so she starts taking video of it. And you can see her breathing is kind of effective. You get a little eye deviation. And then you can see it starts very subtly on the right side, her right side of the mouth and face. And that's it. So another type of seizure that, again, is very easily misdiagnosed. And this last video is a little long. I'm going to skip through it. But this is Cora. I actually corresponded with her mother a little bit, back and forth online. She has cortical displacement, which is a very severe seizure disorder. It's very difficult to treat. And she's kind of like my daughter. She's run the gambit on just about every type of seizure that you can have. And in this particular video, she has most of the seizures that you can have. She has full little myoclonic seizures. And I don't think she has any absent seizures, but she has focal seizures. She has semi-hemispheric seizures, which is the focal seizure just affecting one hemisphere of the brain. And then she has full tonic-clonic seizures. So we'll play this, and like I said, I'll kind of skip through it a little bit so it doesn't take too long. But she narrates in this video a little bit and has some, but you can see how it's kind of starting with that arm, but you can also kind of see how it's affecting her face a little bit. So, but well, the reason why this is called a migrating seizure is that where the disruption is occurring in the brain is changing, causing the seizure type to change and the parts of the body that are affected to change. So this left-handed weakness or left-sided weakness is often seen a lot too, or we saw it in our daughter where she would have that seizure affect just one side of her body. And then it was almost a stroke-like symptom toward that side of the body would be extremely weak after the seizure. So now she's moved on to where it's a lot more effective of her body, not just the arm, but that whole left side of her body now. And then also it's moving from simple to complex to where when these seizures hit, it knocks her out at the same time. So now she's moved from simple to complex. It's affecting that left side of the body, a little bit on the right side, making her unconscious. And then now we're at like a full tonic-clonic seizure to where it's, the left side is convulsing while the right side is more that stiffening. Yeah, back to the regular seizure. So now that's a little myoclonic right there. That wasn't a full-on seizure. And she has a couple of those, and then she goes back into a tonic-clonic. So I'll catch another myoclonic. Now, so there's a little 1/10 of a second seizure, a little myoclonic. And then back into a full tonic-clonic. So this video goes all the way to the point where mom does have to end up giving her rescue medication, the nasal Versed. Or midazolam. It's actually very unpleasant to have shot up your nose. I've yet to see a single patient say that they liked it or enjoyed it, but it is very effective. So I think she's also called the paramedics, which is something anyone should definitely do after giving a rescue medication because it can depress your respiratory rate. But that's something I'll get into a little bit later in the slide. So we've seen the videos of the seizures. Now we'll kind of talk about the different stages, or dive down a little bit more specifically into what the seizures look like, or the stages of it. So you will have not always, but sometimes we'll have what's called an aurora stage. Aurora stage. This can be hallucinations, dizziness. They will smell sometimes certain smells. They'll think they can smell something. I had a pregnant female patient stated that she could smell burning rubber just before she went into a very severe tonic-clonic seizure. And then, they'll have a wider range of emotions, or also they'll have some numbness and tingling. And then once the seizure starts, it starts in that tonic stage where they stiffen up, fall down, they arch their back kind of severely. They have what's something called an epileptic cry. That's something that my daughter actually does. That's kind of how, one of the ways if we're in the other room, we know she's having a seizure, but it almost sounds like she's being electrocuted. It's very distinct sound that they'll make. And then sometimes in this stage is when they'll have incontinence, but not always. Then you go into the clonic phase, which is the convulsions, what everybody typically sees or imagines what a seizure looks like, with the jerky motions, the frothing of the mouth or drooling, and then the blinking eyes. And then once the seizure concludes is where you go into the postical, what we call the postical stage. And that's where they're completely out of it. They're exhausted, they're unconscious, or they're sleepy, and they're they're, like I said, it's like they've run a marathon. They're out of it. So what do we do when we witness a seizure? Most people know, I assume most people will know on this board, but this goes everything from, what we do for a family member, what we do for somebody we see in the street. But the number one thing is to stay calm. I can't tell you how many times I've seen people panic, and I mean full on screaming panic when they see someone having a seizure. That does not help the situation at all. So the most important thing is to stay calm, because if you can stay calm, you can think rationally and you can do the next couple of steps that come up. But staying calm, protect them and place them on their side. If you see them stiffen up and start to fall down, catch them. Move any kind of like hard or sharp objects away from them, anything they can hit themselves on. If you can, place them on their side. Don't force them over into that position if it's not easy, but place them on their side that way that they don't inhale or what we call aspirate any of the saliva or any of the fogging that's coming out of their mouth. And whatever you do, don't attempt to restrain them. Provide positive support and stimulation. I've been to a couple of seminars where they talk about the importance of doing that, patting them on the back, letting them know it's going to be okay. Just being there as a positive, influence on them actually makes a big difference in their outcomes. They don't have a reason for why, but they've seen that's true. And then we want to begin timing the seizure. It's very important to know how long that seizure lasts. And then we also want to count the number of seizures they have and the time it took between each seizure. And then, depending on what your own protocol is with the patient, call 911. But if you witness one in the street, immediately call 911. I kind of talked with Stephanie about this earlier and why I say to immediately activate EMS. And that's because if you don't know this person, you don't know this patient, you don't know their history, you have no idea how long the seizure will last. And there is a delay between the time you call 911 from the time a call taker answers that phone, gets your information from you. They put it through what we call Pro QA, which is like a scripted, computer question answer thing that they have to run through. And then the computer or dispatcher will make the decision to dispatch what equipment and from what station. Then that station has to hear the tones go off, get up, get ready, get out to the ambulance, get out the door, and go to the call. So start to finish, on a good day, from the time you make that call, from the time they show up, is 5 minutes. So that's if there's no traffic. That's if that ambulance that's in that district is available. They may not be anybody available when you make that phone call. They may all be busy on something else, especially now with the coronavirus and COVID. Our EMS system is pretty well taxed. And then if you're capable or not capable, but if you're able to gather any pertinent medical information about that person, or if you know any pertinent medical information about that person, get it. And then have a seizure action plan. If you have a seizure action plan, gather that up. And I will go into what a seizure action plan is more specifically in a little bit. But a seizure action plan is a wealth of information for medics and for the ER and for us, and that's extremely helpful. But I'll go into what the seizure action plan is if you don't already know what it is. So I'll kind of touch briefly on what not to do. If you see somebody have a seizure, don't attempt to restrain them. You can actually cause somebody a lot of damage by trying to hold them still while they're having a seizure. There's actually been times where like people have accidentally broken bones of somebody they're trying to restrain while they're seizing. So do not do that. And then do not place anything in their mouth. I still can't tell you how irritated I get with, medical shows on TV where somebody has a seizure and the first thing they do is say, put something in their mouth to keep them from choking on their tongue. Well, it's physically impossible to choke on your own tongue. That's a complete falsehood, and it cannot happen. So the only thing that you're going to do is cause damage to the mouth or possibly break off teeth by trying to put something in there. So I told you what we should, the biggest or most important piece of information that you can have on scene will be that seizure action plan. And that's something for you, or if you have a family member with epilepsy, or if you know somebody that has epilepsy, to suggest to them to put together. A seizure action plan is immensely important for medics and for the ER staff, because the ER staff may not, like what we ran into constantly with our daughter. We tell her she has Dravet Syndrome, and everybody in the room looks at us with a blank stare, like, what's that? So every time we go to the ER, we have to re-explain what her disorder is, what medications will make her disorder worse or make the seizures worse, and what medications she can take. And then also, if you're like us and you're on a clinical trial for medication, there's drugs that you cannot take while you're on these clinical trials because of drug interaction, or it could cause you to be kicked out of the trial. So I always suggest having a seizure action plan like what we have here for at home. Comes in a little 3-ring binder. And I'll show you a link at the end of this presentation on where you can get a template for a seizure action plan. But it's amazing to me how many paramedics, doctors, and people that have suffered with epilepsy their whole life have never heard of what a seizure action plan is. But we keep ours at home in a little purple 3-ring binder, kind of outlines on the front, some basics on what to do, what not to do, kind of like in this presentation. And then as you open it up, it'll have some basic medical information about her with a picture. It'll show her current weight, current height. These are all very important things for the medics to have, because they need to know height and weight before they give certain rescue medications. It'll show what her medical condition is. Hers is intractable epilepsy, Dravet syndrome, and I'll explain what intractable is here in a minute. Autism and intellectual disability. So they are not still asking her over and over again if she's okay, because she doesn't understand what they're saying. So, and this is also very important to have at school or daycare or her therapy, because there will be times where my wife and I are at work and we're not able to go with her in the ambulance to the hospital. So the school or the daycare or the therapy can send this with her, so the medics know exactly what they can do or not do. Put her insurance information in here. And then we also have her listed prohibited medications or excluded medications. And then we have a letter in here from her epileptologist, and it's basically outlines, line for line, her treatment when she gets to the ER. So the ER doctor doesn't have to ask any questions or work with any kind of hesitation. He knows exactly what medications to give to her, when, how much, and how long a period to administer that medication over. So this takes all the guesswork out of everything for the paramedics and for the ER doctors. And then we also have a list of contacts in the back, our contact information, email addresses, our Lynn and my parents, everything on there, to where they can at least get a hold of somebody. If for whatever reason I'm on a call or something and I can't answer the phone or something like that happens, which has happened in the past, where I'm on an EMS call or a fire call and my phone is ringing in my pocket, but I can't answer it because we're on scene trying to do our job. And then I already touched on medics and for the ER. So post-seizure, we recommend that they always be placed in this post-ical recovery position or post-seizure recovery position. This is that position you put them into if you can't place them on their side while they're having the seizure. But kind of position their hand under their face. If you don't have like a piece of clothing or a bag or something you can put under their head, and then you roll them over onto their side. And we call this the lateral recumbent recovery position, or lateral recovery position. And this does kind of the same thing. It keeps them from aspirating any fluids or choking on anything. Sometimes they do vomit, and it keeps them from choking on that. And then, what to expect of us, the first responders when we get there. It's kind of the same information I showed you before. They're going to ask you the length of the seizure, or the length of time, the number of seizures that they had, the time between seizures, the age, history or medical history, if any kind of rescue meds were given, if they were, what type and what dose. And then if you have the seizure action plan, you can just tell them, the basics of the length, the number, and time, and then you can hand them that seizure action plan, and I have all the other information right there for them. They can look at, and they know what medication to give next, and then they'll know what hospital to take them to, and then they know that when they call their medical control, they can tell their medical control what's in that seizure action plan, and be able to tell them exactly what's going on. And then our medical control will call the ER and let them know exactly what to expect coming in that ambulance within the next 5 to 10 minutes. So what is it like to live with epilepsy? Most of you who are adults who have epilepsy know this already, but this is more for, medics to understand what it's like for our patients to live with epilepsy. And it's for family members to kind of understand what their family member who has epilepsy, or understand what it's like for a caregiver, like, for the parents who are caring for a child who has epilepsy. But with living with epilepsy, there's comorbidities. I'll talk about what that is, along with the risk factors. There's the anti-epileptic drugs that they take, their side effects, how they affect a person. And then, what kind of quality of life can we expect, or can someone expect for that person to have? Comorbidities with epilepsy are, like I mentioned before, the broken bones or head injuries from falls. A lot of people with epilepsy suffer from sleep disorders. They're actually not 100% sure why this is, but I can firmly testify to this, and my daughter does not sleep. She keeps us up all night long. A lot of mental health conditions like autism and ADHD, which my daughter suffers from both. Depression and anxiety are often go hand in hand with epilepsy. Heart disease is very often associated with it. They don't know why, but for whatever reason, they've seen a lot of people who have epilepsy also suffer from heart disease. And then suicide, and then attempted suicide runs very high under people that have epilepsy. So what are some risk factors? So you have something that's called status epilepticus, and another thing which is called SUDEP. So what status epilepticus is a single epileptic seizure lasting longer than 5 minutes, or 2 or more seizures within a 5-minute period. So the previous definition for this was a seizure that lasted 30 minutes or longer. They since have done away with that previous definition upon realizing how dangerous it is for people to have seizures that's longer than 5 minutes, or the 2 or more seizures, without returning to normal between them. Status epilepticus is a true medical emergency, has a high mortality rate, and it needs to be addressed as soon as possible by the medics. And that's kind of goes back into why I suggest that if you witness somebody having a seizure on the street, or if it's not within your personal or particular protocol, to call EMS as soon as possible. Call 911 as quick as you can to get them en route. And then we have SUDEP. Now, SUDEP stands for sudden unexpected death from epilepsy. It's where the person will have a seizure, and then during or after the seizure in a post-ictal period, they will pass away. They don't know if it's because the body uses itself up during the seizure, or if there's some other kind of medical emergency that's happening during the seizure, such as a heart attack or a stroke. A lot of times it happens at night, though, and it can happen while they're sleeping, when it actually most often happens. They don't know if it happens because of a seizure while they're sleeping, or if it's a seizure that the disruption occurs. There's one theory that the disruption occurs within the brainstem, actually affecting the heart rate and breathing, which causes the sudden unexpected death. But this highlights the importance of having a seizure monitor. We have 2. We used to have 3, but one of them it's gotten too old to work effectively. But we have 2 for keeping an eye on Alyssa when she's sleeping, to let us know if she has a seizure, we can act or know what's going on. And we also have a pulse oximeter monitor as well, to where if she's has a seizure and is post-ical, we can put that monitor on her and keep an eye on her, while she's in that post-ical phase until she wakes up. So, and then we have the anti-epileptic drugs and the side effects that go along with them. Most anti-epileptic drugs cause dizziness or drowsiness. A lot of times it can cause depression or suicidal thoughts. So then you have a person that already has, depression and anxiety, and then you give them a drug that's going to cause depression and anxiety, it compounds the effect. A lot of times it will cause loss of appetite, which is the case of my daughter, or it can cause weight gain. So you can have either or. It can cause liver damage, acute liver failure, dependence. A lot of these drugs are addictive. Upset stomach, birth defects, headaches, difficulty sleeping when you already have trouble sleeping, rash, and then some anti-epileptic drugs can cause seizures. So I really hit this slide hard in my paramedic class because I want the medics to understand what people who have this disorder are dealing with. They have a disorder that's already affects the quality of life, and then they're faced with the decision of taking medications that could make it worse. So I kind of want them to understand that people that have epilepsy suffer from far more than just the seizures that go along with it. They have all these comorbidities and the side effects of their drugs. And I can personally attest, I took gabapentin, which is a seizure medication. I took it for nerve pain in my back, which it did nothing for the nerve pain. But I was taking a very high dose of it, and it made me feel awful. I did not like taking it. And I mean, it helped with the nerve pain a little bit, but not enough to where it was worth it for me. So I just suffered with the back pain rather than take the gabapentin. So I can completely understand why somebody would choose not to take some of these anti-seizure drugs and just choose to manage the seizures as best they can through diet or through lifestyle. So all this wraps around into like not only that how it affects the quality of life, but a better understanding for us as in the EMS system and doctors and then family members. But how does this affect quality of life and their quality of life? It's a spectrum, and like I said at the very beginning of this presentation, it can have a minimal effect on them. They can, like Julius Caesar ruled the Roman Empire, and he had severe epilepsy, or it can be like my daughter, to where it's very detrimental and life altering, and she requires care 100% of the time. So it can run a full effect, and then that spectrum just doesn't affect the patient, but it affects family members as well and their quality of life. So I always, challenge medics and family members to be empathetic of those family members or the people that suffer from epilepsy, to empathize with them, and not just sympathize, not just say you feel sorry, but truly empathize with them to understand that what they're going through and what the family is going through is difficult. So how do we improve this outcome though? How can we make changes to where we're helping them with their outcome and their quality of life? And one of them is to get early diagnosis, and early diagnosis means early treatment. And more importantly, it can be the correct treatment. So what kind of doctor do they get referred to? So one type of doctor that you refer to is a neurologist. And then, so a neurologist is a doctor that kind of specializes in that umbrella of neurological disorders, whether it is ADHD, hyperactivity, Tourette's, seizures. A neurologist will operate under that full umbrella. And then you also have something that's called an epileptologist. So what is the difference between an epileptologist and a neurologist? And the answer is quite a bit, actually. So if you ask a neurologist what's the difference, like I did, the answer isn't always pleasant. They get a little offended. They think that they just had a couple extra days of training in med school and now they're called an epileptologist. But as we found out, the truth can be more different. An epileptologist is going to specifically specialize in epilepsy, epileptic seizures, the different seizure disorders, anticonvulsants, specifically anticonvulsants and special situations involving seizures, such as women who are pregnant and suffering from seizures. They also will specialize in intractable epilepsy or refractory epilepsy, which is a it's a medication-resistant form of epilepsy, which my daughter has, where she'll try and fail multiple medications. So it's called pharmaco-resistant epilepsy. So when should somebody be referred to an epileptologist? So if the patient has persistent seizures, even while on medications for those seizures. When the patient has tried and failed multiple medications, that's why we call refractory or intractable, or pharmaco-resistant epilepsy. That's a mouthful. If they're experiencing side effects from the medications, when there's comorbidities involved, and I talked about the comorbidities earlier, and very specifically if they're having trouble or difficulty getting a diagnosis. And you can almost, I'm going to go back one, but you can almost anyone that you can think of that suffers from epilepsy can identify with a bullet point on this list. So I'm a strong advocate for, if you have epilepsy, that you should try your best to get in touch with an epileptologist. A big reason why is because there can be a delay of up to, and there has been a delay with patients for up to 15 years to finally getting that referral or getting in to see an epileptologist. And then the real surprising part was 40% of those people who finally got in with an epileptologist found out that they were diagnosed incorrectly in the first place. And an incorrect diagnosis means getting incorrect treatment. It gets the wrong drugs, and then wrong medications and wrong treatments can make disorders worse. Case in point was my daughter. She was diagnosed with just generalized epilepsy. And we were very, very fortunate that she was not given, there's certain first-line drugs which are actually, they're called sodium channel blockers. Well, my daughter's disorder is a sodium channel disorder. The sodium channels in her brain aren't developing correctly. And had we given her these sodium channel blockers, it would have exponentially made her disorder worse and had a much worse outcome. So that's why this early diagnosis and treatment is so important. And then, I'd leave this in here even though, but why do so many patients experience a delay in referral? And I explain this to medics and doctors because a lot of people just flabbergasted on why people don't go see the right doctor. Well, the information isn't always readily out there, readily available. Some doctors don't always recommend somebody get a second opinion because they don't want to recommend their patient away. Some doctors don't believe in an epileptologist. And also people deal with and struggle with the cost of epilepsy, the cost of insurance, the cost of these medical visits, the cost of seeing a specialist. So it's not just as simple for a lot of people, as I'm sure many of you know, as just getting in to see the right doctor isn't always that easy. So that kind of concludes my presentation. I put on here just some resources that I found to be useful for me, and I often tell the medics to refer to patients with this information, but a real simple one is just epilepsy.com. There's a wealth of information on there about, you can get linked over to other organizations, charity groups. There's all kinds of information in there available to you. Another one is rarediseases.org, or the National Organization of Rare Diseases, or Rare Disorders, I'm sorry. I found out all kinds of information about my daughter's disorder that I didn't know about just from going to that website. And it was very, very useful for me to use in putting together this presentation and for researching more about my daughter's disorder. So rarediseases.org is a great tool to use. Medscape is just kind of some general medical information that you can Google about whether you have questions about medications, studies on medications, or studies about disorders. And then also, I put in here a link to what a seizure action plan looks like. So you can go to the epilepsy.com, and they have a link in there to where you can go, or you can just do a Google for a seizure action plan, but it'll pull up a template for you to use. See if I can get this on the screen, to use in making your own seizure action plan, or to start with. So it has, some basic information on here. You can list when the seizure type, how long it lasted, how many times it occurred. So kind of a basic template for you to start with for your seizure action plan, to keep at home or to keep at daycare or to keep at school. But I'm a very strong advocate for these, because when a medic gets on scene, he's just going to assume that your child has generalized epilepsy and not know how much further, how far in depth, and the ER is not going to know how much further, how much more in depth to go with their treatment plan. So that concludes my presentation. I really hope that you guys found it beneficial and informative. I think Stephanie was gonna, if anybody had any questions, you could type it in the comment box and you can ask it that way, and Stephanie was gonna ask me the questions. But, oops.
I don't see anything right now, Elliot, but thank you just so much for your, just the breadth of information that you provided everyone. I know that we all can connect with you doing your job both as a first responder and as a parent, and I just really appreciate you taking the time today to educate all of us.
Yeah, I appreciate, anybody that dialed in. I appreciate y'all taking time to sit through it. And like I said, hopefully you got something out of it. Hopefully I wasn't preaching to the choir the whole time, but hopefully you got some good useful information out of it, or some good, resources out of it. And once again, that seizure action plan is very important. I went and taught this class to Garland Fire Department, the city of Mesquite, Highland Park, all those different departments, and nobody in those departments had ever heard of a seizure action plan. And more surprisingly, I had talked to the ROC, which is basically a conference of doctors in North Texas, doctors and nurses, to get together for these conferences. And I had 20 minutes to do this, almost the same presentation. I burned through it, but I really hit hard on a seizure action plan. And none of the doctors and nurses in that conference had heard of a seizure action plan. So if you have that, if you don't take anything else away from this, that's why I harp on the hardest or the most, is having that seizure action plan available for the medics to take with them to the ER. So.
Excellent. Well,